Yeah, and now followed by we have our next speaker, Miss Tanuja Bhabre. Sorry, she's going to speak she's going to speak on behalf of Dr. Aparna Joshi and Miss Sindhura Tamanna. So, a little brief on her. Ms. Tanuja Bhabre has completed her master's in counseling psychology from Tata Institute of Social Science. She's been working in the area of mental health wellness for 6 years, and she has been awarded for the most creative counselor of the year 2014 by Arpan. She has worked in implementing and strengthening various ways of mental health programs across countries. So please welcome her for her topic on responding to suicide and self-harm amongst adolescents and young people in India. Thank you.
So much for having us here today. Good afternoon to everybody. I am here representing a service and an organization which is Tata Institute of Social Sciences. Within Tata Institute of Social Sciences, I'm representing Icall, which is a field action project run within TISS, which is a technology assisted service. The paper that I'm going to be presenting today is co-authored by two more of my colleagues who couldn't be here today, unfortunately. Dr. Aparna Joshi, who's a faculty at the School of Human Ecology in TISS, and my colleague, Ms. Sindhura Tamanna, who's a senior research officer at Icall. My name is Tanuja. I serve as the program coordinator of Icall. And I'm going to be talking about Icall's experiences of responding to concerns related to suicide, self-harm, which is suicidal ideation, suicidal attempts, and non-suicidal self-harm, and our response to it. I'm also going to be talking about maybe some best practices, guiding values, and some of the implications that we feel have come out as an outcome of mental health professionals trying to work in this field. So just to sort of give a background, I think we all talk about youth and their use of technology, mobile phones, and a lot is spoken about how technology is being used, whether it's good, whether it's bad. Dominant narrative also talks about the side effects of using technology and how that impacts the lives of young people in India. But what is it that young people are using technology for? They're using it for communication, for entertainment, for connecting with each other, for maintaining relationships, and also as a means of self-expression. Some of the concerns that are also being spoken about with related to use of technology might be related to physical health impact of using technological gadgets, impact related to loss of interest in other offline activities, and excessive use dependence, and how use of technology interferes with social connections. But I think I'm going to be talking about something very important today in terms of how youth and young people in India are using technology for expressing themselves, for seeking help, and for seeking support when they identify themselves as being vulnerable or as being in a state of crisis. So just to give a brief about what are the concerns of young people in India. So a lot of research talks about academic and career-related pressure, low sexual and reproductive health-related information, issue of early marriage, patriarchy, gender norms, substance abuse, suicide, self-harm, mental illness, violence, abuse, and poverty. Now, just to dive deep into this particular area, about 150 million people in India are in need of mental health care services. And at the same time, almost 20% of young people are likely to experience some form of mental illness. There is also concern related to high-risk sexual behavior, and estimates say that about 150 million adolescents and young people engage in use of tobacco, harmful alcohol use, or even addictive behaviors. When I'm talking about addictive behaviors, these could be habitual addictions and not necessarily just substance-related. So about almost 19 to 42.8% adolescent females have also reported experiencing domestic violence. I think the team from Sehat spoke extensively about the kind of concerns and the kind of stressors that they come in into the area of violence. So now just looking at a little bit closely about the issue of suicide and self-harm. So India has the highest rate. I think it's no surprise that India has the highest rate of suicide when we're talking about as comparing it to the world. And almost 40% of suicides in India are committed by persons who are below the age of 30. India witnesses between 1.35 to 2.5 lakh suicides per year. I'm sure all of you know that suicide is one of the biggest reason for deaths when it comes to young people in India, which is within the age group of 15 to 24 years of age. So India in the last 10 years has seen almost 22.7% increase in the rate of suicides, and the documentation that we have is of committed suicides. So which also research also says that if there is one completed suicide that has happened, which means that there are 10 attempts which have been made. So just try and think about the magnitude of this issue and the number of people dealing with these concerns. And when we talk about non-suicidal self-harm, while there is little documentation available about it, newer researchers which are coming up are talking about almost 33.8% young people and adolescents engage in non-suicidal self-harm. How does now technology come in as a response to these problems? I think before I dive into this problem, I'd also like you to think about, and I'm sure that take a moment and think about one young person or one person that you knew, who had heard of, or have spoken to, or have worked with, has dealt with suicidal ideations or extreme vulnerability. And I'm sure that each one of us in the room will be able to name multiple people, because that is how serious the concern is, and that is how difficult the problem is. So young people, when we're talking about, everybody talks about young people and the kind of resources they need access to. At some points, we sort of end up taking a paternalistic view and say that, this is what you should follow. And whereas there are also models which talk about, we need to listen to the voices of young people and understand where is it that they want to take their futures, their careers, and their aspirations. So they are almost at the cusp of sort of these two worlds, whereby they're trying to hold on to what already exists, the culture, the ideas, beliefs, and at the same time trying to break norms and explore what is coming their way. And these two worlds are sort of really different. And a lot of times dealing between these two worlds can be challenging. So needless to say that young people are in need of support, and at the same time there's a huge treatment gap when we talk about mental health services available in India. So as a response to these services, I'm going to be presenting the work that Icall has done, which made an attempt to go beyond the issue of geography, immediacy, and accessibility for people across the country, and to demonstrate how a technology-assisted service can be effective and can offer a response to these concerns. So what is it that I'm going to be talking about Icall? So just to give a brief before I present the findings, Icall is a service that which is a technology-assisted service whereby we offer counseling over telephone, email, and chat. We aspire to become an accessible, affordable service whereby Icall services can be accessed from any part of the country, we run 6 days a week, 14 hours a day, so you can reach out from any part of the country. Our services are multilingual, so as to reach to more number of people. And most importantly, our services are confidential and anonymous. So anybody who's reaching out to Icall doesn't have to share their name, class, caste, gender, anything, and can immediately talk to a counselor about their concerns. The vision behind starting Icall was also that good quality ethical mental health services should not be a luxury and should not be determined by, the access to it should not be determined by where I live, what kind of resources I have access to. So we were very clear that we wanted to make good quality ethical mental health services available within the reach of anybody who's in distress. So we offer counseling over 3 mediums. We cater to a range of psychosocial issues across the lifespan. We offer services in 10 regional languages. All the counselors who work with us are dedicated full-time professional counselors. When we talk about young people, I think the focus for us is very special over there because Icall services, almost 40% of Icall services are accessed by clients who fall within the age group of adolescents and young people. Uh, we believe that Icall services are youth-friendly. We respect diversity. We respect intersectionality, whereby we understand that people come from a social location and their social realities determine and contribute to their mental health problems. Also determine how is it that they will recover from these problems. So we feel that it's very much our job to respond to psychosocial concerns within their psychosocial reality and not treat them in silos as individuals. Icall believes in a very strengths-based, non-pathologizing approach. This is also to keep in mind that there is a lot of stigma which is there around people, especially when we are talking about the issue of suicide, self-harm. People go through extreme helplessness, vulnerability, and this is to also constantly remind that people are resourceful. They have the resources to be able to cope with their problems, and we as mental health professionals need to be able to help them find those resources for themselves. And I think apart from services, we engage in research, capacity building, outreach, and awareness creation. So just the methodology of this current paper, the data that has been drawn is from Icall service database, and I'm going to be presenting the data of 722 sessions on the issue of suicide and self-harm. The age group that we are going to be looking at is 15 to 24 years old. These are concerns related to suicide and non-suicidal self-harm. Whenever an Icall counselor receives a call or a chat or an email, it's documented within Icall's own software, and some of them are mandatory and non-mandatory fields. The data has been derived from that software and has been analyzed thematically. We've used descriptive statistics to share the data as we go ahead. And at the same time, the paper is going to be talking about what is the profile of callers who are reaching out with these issues, and what are some of the interventions that we have been able to employ. So just to begin with, what are some of the reasons that we understand that people access services within technology-assisted mediums? So one of the things is that, of course, there's lack of availability of services. There's lack of ease and convenience to access services which already exist. There's a lot of stigma around mental health services, and a lot of times young people may not always be able to afford services which exist already. So a medium such as Icall offers them anonymity, immediate access, immediate and easy access, and is affordable to them because the services are free of cost. Just to define, we have coded the data into 3 categories. The first category is suicidal ideation. Suicidal ideations pertains to sessions whereby clients expressed wish to where they express thoughts of suicide, plans, or a death wish, but these were at a thought level, whereby they felt that they were able to control it, and they were just going through immense amount of distress and were experiencing this issue. The category of suicide attempt involves sessions where clients who had either attempted a suicide very recently or were on the cusp of planning and or making an attempt. So the data has been divided on the basis of intensity of suicidal ideations. The third category of non-suicidal self-harm pertained to conversations where young people described acts which included cutting, headbanging, biting, binging, etc., and triggers related to self-harm and care which can be taken. So these are sessions whereby clients may have expressed a desire to want to engage in non-suicidal self-harm, or would have also engaged in it already and then reached out to us. So just to present the numbers a little bit more, almost 89% of the calls were under the category of suicidal ideation. 4% of sessions were under the category of suicide attempt, and about 6% sessions were under the category of non-suicidal self-harm. Something very interesting to observe is that the number of female clients who have accessed Icall services for this particular issue are significantly higher, almost twice as higher as compared to clients who identified as male. When it came to the category of non-suicidal self-harm, almost 46 female clients accessed the service for this issue, whereas there was only one male client who reached out for the issue of non-suicidal self-harm. When it came to suicide attempt, again, 24 clients reached out to the service who were female, and there were 5 clients who reached out who identified as male. Similarly, when it came to suicidal ideations, almost 53% of clients who identified as female reached out, whereas 35.7% clients identified as male. Next. So this is just a gender breakup. Almost 37% of clients were male and 63% of clients were female. Which is also, if you look at the larger research, female clients have been found to make more attempts, whereas male clients who are experiencing suicidal ideations have been found to, their attempts have been found to more successful as compared to females. When we look at the language, and the language is also slightly sort of impacted because Icall has a presence in a city like Mumbai, and you'll see those sort of trends reflect also when I talk about locations. Majority of our clients, almost 60% spoke in English, 37% spoke in Hindi, 1% in Marathi, and little less than 1% were Bengali, Telugu, and Tamil speaking clients. The relationship status of clients involved about 55% clients reported that they were single, 25% clients said that they were in a relationship, 2% clients said that they were engaged, 3% clients said that they were married, a little less than 1% clients said that they were separated and divorced. So it's also important to understand that we're talking about the age group of 15 to 25, and there are clients who are reporting who are reaching out, who are married, or some of them who are already separated, or some of them who have already undergone a divorce. This is just a location breakup. So the top locations for us from where these clients reached out were Maharashtra, followed by Karnataka, and then followed by West Bengal. But you can see that the clients who have reached out to us are spread across the country, even different union territories from where they have reached out to us. Next. So just some presentation of some of the concerns that clients brought in. Under suicidality, so the first narrative is a female client who's in a same-sex relationship, who's speaking about breaking up with her girlfriend, having concerns related to her own, how she appears, how she looks, her own self-image, and at the same time, how this relationship loss has impacted her. The second presentation is of the client who identifies as male, has spoken about both my parents have been alcoholic and now they have facing severe health concerns, frequent hospitalization. I too drink as it helps me cope with all the burden I'm carrying. I feel lonely and unsupported. No other relatives have helped us through this, and I'm now feeling suicidal thoughts every day. The next narrative is of a client who is male, 22 years of age, who said that, who reached out to us when just before almost trying to make an attempt, whereby he said that मैं अपने hostel के terrace पर खड़ा हूँ, I'm standing on the terrace of my hostel, और कूदना चाहता हूँ, and I wish to jump. मैंने 12 दिन पहले भी कोशिश की थी पर बच गया. I made an attempt even 12 days back, but I was saved. घर वाले कोई भी बात नहीं करते हैं क्योंकि मैं ड्रग्स करता था, कोई मुझे समझ नहीं सकता. Whereby he's saying that my family members don't really speak to me because I had a history of drug use, but I feel that nobody can really understand me. The next narrative is of a client, female, 21 years of age, speaking about having suicidal thoughts since a long time. I will need a lot of courage to take that final step, but if it gives me relief, perhaps I should try it. These are some narratives on self-harm, whereby the client is talking about, this is an 18-year-old female client, saying that I can't take the pain anymore. I just want to cut. I self-harmed last night using a safety pin. There is no trigger perhaps, but I have been really distressed due to my examinations. The next client is saying that मैंने कल ब्लेड खरीदे, मेरा कज़िन आया था जिसने मुझे फिर से प्राइवेट बॉडी पार्ट पर हाथ लगाया, मैं किसी को बता नहीं सकती इसके बारे में, मुझे बहुत अकेला लगता है. Whereby the client is saying that they went and purchased blades in order to make an attempt to self-harm, and is feeling really distressed because a cousin has violated her, and there's a history of sexual abuse as well, and at the same time sharing that I can't share this with anybody, and I feel really, really lonely. So similarly, clients have been reaching out with different sort of concerns. Sometimes they are ideations or desires to want to engage in a certain activity, and at the same time, sometimes they are almost about to make an attempt, and then they choose to reach out to a service like us. So what is our understanding of suicide? So we look at suicide as on a continuum, whereby at one end there could be death wishes, and whereas on the other end there could be an active crisis, whereby perhaps the person may have already made an attempt or is just about to make an attempt. So therefore, we look at suicidal ideations and thoughts through different intensities and through different frequencies. There could be suicidal urges, and at the same time there could be past as well as recent attempts. Next. When it comes to self-harm, again, similarly, there is the category that we're talking about is non-suicidal self-harm. But a lot of times we have also worked with clients who started with self-harm, and if the distress increased, they started feeling suicidal. And so there's a very fine line between suicidal and non-suicidal self-harm. And as mental health professionals, we also struggle to constantly be able to find that line. We look at self-harm as a coping mechanism and as a trauma response to something that clients are going through in their life, and this is something that helps them cope with their current distress, pain, loneliness, or whatever it is that they are experiencing. So some of the guiding values that we have kept in mind when we look at responding to these concerns, one of the most important thing is that we believe that clients have a right to autonomy, which means that clients have a right to make decisions and make choices. So if they are choosing to make these choices, of course they have used and perhaps even exhausted the kind of resources that they have access to, and then have come to this stage whereby they are doing this. So as mental health professionals, it's really important for us to constantly work with them in a collaborative manner and try and understand and try and remember that these are people who are capable of making their own decisions, who have the right to make their own decisions, and not take a paternalistic stance or not take a stance whereby we override their right to make their choices. They have a right to confidentiality, right to non-maleficence, and at the same time, collaborative treatment stance. So what are some of the ways in which we have been able to respond? I think one of the first stages for us is trying to identify the crisis as a crisis. So when the client is going through that concern, trying to correctly identify that this is what it is. When it comes to suicidal ideations, when it comes to non-suicidal self-harm or even attempts, understanding the language, understanding the narrative that the client is sharing, and to be able to pick that this is what the client is perhaps talking about. Assessing their safety and lethality. Safety in terms of how safe do they feel to be able to control the thoughts that they are experiencing at this point of time. If they have a plan, have they already collected everything which is required to execute the plan? Post which we talk to them about confidentiality and policy related to that. If we identify a situation whereby we believe that the intensity and the frequency is high, then we work with the client to be able to identify a trusted adult and make a breach. We don't believe that, you know, the trusted adult is always necessarily a parent for all young people. A lot of times they are teachers, maybe friends, elder brothers, sisters, and we work with them to try and identify who that adult is for them. When we are breaching any sort of confidentiality, we also keep in mind that it's not, we seek consent to be able to breach at every stage, and it's not a blanket consent which is sought from clients, which means that we'll seek specific consent to try and understand what kind of data is it that we can share. So it doesn't mean that we are going to reach out to the trusted adult and share everything that they are going through, but seek consent from the client to figure out what is the information that should be shared. We seek the identifying data from the client. Because we are a helpline service, we don't have access to identifying data of the client. So we work with the client to access that data, which may be phone number, their immediate location, where is it that they are calling from, maybe their address at times if required. Then we work on identifying and activating the safe person. And then we also work with them to be able to identify certain resources and help with them with short-term stabilizing strategies. These strategies sometimes could be, just getting rid of the material that you have. A lot of times in self-harm related concerns, we also work on, how is it that you can distance yourself from the means that you have gathered in order to engage in this self-harm. Or we work on making coping cards, we work on making, reaching out to different resource persons within their lives. Sometimes it could be pets, sometimes it could be friends, which will just help you delay the thought that you are experiencing. Post that, we also connect clients to different referral systems. A lot of times clients reach out for different issues, and what happens is that we are clear that just speaking to us is not going to resolve the problem. Therefore, it means that we may have to activate, say, different organizations, different NGOs, maybe mental health professionals who are working in face-to-face settings, maybe there are certain, professionals, maybe medical healthcare services, and depending on the client's concern, we work on activating these resources. We also continue to work with the clients to be able to bridge this referral, whereby we reach out to the organization and say that, this is a kind of concern, would you be able to handle? This is, of course, done with the consent of the client, and then we facilitate those referrals. When these referrals are made, it doesn't mean that we stop offering services. We continue to offer services to clients, but at the same time, we try and ensure that we add on to the coping that they already have. Post which we look at making a pact and setting up callback consent. Depending on the nature of crisis, our counselors may seek consent related to, say, an hour or a day later or 2 days later, and this sort of follow-up continues until until we feel that the client is in a stable space. Next. So certain things to just talk about the interventions that we implement and the kind of perspectives that we use while implementing these interventions. I think one of the most important thing is that we adopt a psychosocial perspective, which means that, as I said earlier, that we believe that problems don't exist in isolation, but they exist in the client's psychosocial reality. So we work with the clients to be able to understand violence, discrimination, trauma, difficulties that they may be going through, and how that contributes to their well-being, and at the same time, how is it that we can work on changing those things to equip them for a better coping. We also aspire to move away from an individualistic pathologizing psychology-based paradigm, which, so there won't be any diagnosis that will be given to the client, there won't be any labeling that will be done to the client, and the kind of services that are offered are really offered in a non-judgmental safe space. When we talk about any kind of work related to suicide and self-harm, I think the most important thing is to be able to create hope within the client's narrative, so that also doesn't mean that is done by giving false assurances, but at the same time saying that, however long it takes and whatever it takes, we are here to help you through this, and we are going to do this together. The kind of space that we offer, as I said, is validating, non-judgmental, and non-moralizing. At no point will we judge the client's choice or say, something that Chitra was saying sometime back, saying that why did you do this? Why did you think this was the right decision? Or saying that why didn't you think about your family? What will God say if you did this? So we don't engage in a narrative such as that, and know that people make choices for certain reason, and respect them for those choices. We believe that the client has autonomy, has the resources to be able to cope with their problems, and at the same time, it's our job to help them strengthen those resources or perhaps build more resources. So we work on finding exceptions to the dominant narrative, to the dominant social scripts that they might be existing, which is related to their gender, male, female, class, caste, religion, and we explore and unpack these narratives and as to how is it that they are contributing to their mental health and recovery. We try and build an affirmative stance by trying to connect client to their preferred psychosocial realities, avenues, people, network, and resources. And I think the most important thing is the kind of stance that we take is extremely affirmative, empowerment-oriented, whereby we try and work on building different skills. We take a rights-based stance, whereby we say that, clients young people especially have certain rights, and it's our job to foster them, and it's our job to also respect them. So just to sort of wrap up, I'm going to be talking about certain implications that we feel that as a service, it's something important when we're talking about working in the area of crisis prevention and suicide and self-harm prevention. Next. So I think one of the most important thing is that we feel that it's extremely important to be connected to ground level services. As a technology assisted service, it's not enough for us to offer services over technology. It's also very much our responsibility to connect to resources which exist on ground and equip clients with those. It's important for the counselors to seek supervision and team support because crisis intervention is not easy or possible when you're trying to implement it as an individual. One of the most important thing is also addressing vicarious trauma for the counselors who are offering these services, because it can become really, really taxing and difficult for them. And at the same time, the questions that we try and answer when we are working with each case whereby clients are feeling suicidal, there are a lot of ethical, moral dilemmas which are going through. And all the research on ethics says that if there are no defined values or guidelines which tell that what is it that is to be done, the mental health professionals or helping professionals tend to go back to what is it that they feel is right, which means that their personal values, which sometimes could be causing harm to the client. So it's really important as an organization to define their own stance and values when it comes to this particular issue. And I think lastly, it's really important to develop protocols and metrics for escalation to define each step as to how is it that a particular crisis should be handled when it occurs. These are just the contact details of Icall. It's a service which is available free of cost. If anybody likes, they can reach out to us. Thank you.
Yeah, thank you very much. Thank you, Ms. Tanuja Bhabre, for a wonderful insight again on the possible support that we have in India and the helpline that we can ask people to reach out to. In the workshop that we conduct at Sisters Living Work for suicide prevention, we do share this helpline and ask maximum people to reach out. So thank you, audience, for being attentive so far.